Hello, everybody. My name is Ashley Wild, and I'm an infectious diseases pharmacist at the Norton Infectious Diseases Institute. And I'm here today for the Norton Infectious Diseases Institute Grand Rounds to introduce Clover Truong, who's one of our infectious diseases clinical pharmacists at Norton Brownsboro Hospital. And today she's going to be talking about the ins and outs of ESBL management.
Thank you, Ashley, for the introduction. Hi again, my name is Clover, and today I will talk a little bit like how you should approach a patient with an ESBL bacteria growing in a culture to optimize patient care. So the objective for today's presentation, by the end of this presentation, you should be able to apply the 3 moments of antibiotic decision so that we can optimize the care in patients with an ESBL organism growing bacterial culture. You should also be able to understand the risk compared to the benefit when we use a carbapenem compared to a non-carbapenem therapy in the treatment for ESBL infection. So what is an ESBL? Let's refresh ourselves a little bit from the last presentation from Dr. Truong. So ESBL actually stands for extended spectrum beta-lactamase. So basically, it's an enzyme that breaks down what is so-called the newly developed extended spectrum cephalosporin. So when I talk about extended spectrum cephalosporin, your mind probably go to something like cefepime, right? Our 4th generation of cephalosporin. But remember that this ESBL term is coined way back in 1960s and 70s. So way back when what is considered to be an extended spectrum cephalosporin is actually our 2nd and 3rd generation cephalosporin. So nowadays we usually refer them to as, for example, like ceftriaxone and cefotaxime. Whenever an organism that produces an enzyme like an ESBL, they tend to break down multiple different category of beta-lactam antibiotics, for example, like penicillin, most cephalosporin, and H2N. So that's why we consider them to be a multi-drug resistant organism. You may have asked, like, which bacteria produce an ESBL? Actually, any gram-negative bacteria can produce an ESBL, but the most common one that probably give you a lot of headache in your daily practice would be an E. coli, Klebsiella pneumoniae, Klebsiella oxystoca, or Proteus mirabilis. There's one myth that I want to debunk related to an ESBL before we move on into how do we manage those patients, is that even though an ESBL is considered multi-drug resistant organism, it does not tell us or not really affect how a non-beta-lactam antibiotic work, right? So just because an E. coli, for example, produce an ESBL, it doesn't tell us, it should not affect the susceptibility of trimethoprim sulfamethoxazole, for example. So why do we care so much about an ESBL? It is, in fact, the CDC, the Center for Disease Control and Prevention, even consider an ESBL organism to be a serious threat. And that's because, as I mentioned, it's a multi-drug resistant organism. So it limited our antibiotic choice that we can use to take care of these patients. Another thing that's very serious about this is we have an alarming increasing case of an ESBL. As you can see in the figure, just between 2012 and 2017, we have like 50% increase in the number of cases of infection caused by an ESBL. And what is even more alarming is that most of those cases happen in the community onset. So the ESBL no longer gets contained in a hospital and affect the hospitalization. Like a lot of these patients got affected just being in a community. So what are some of the risk factors for patients who get infected with the ESBL? So this list is not meant to be all-inclusive, right? But some of the most common ones include like if the patient have recent antibiotic use, recent hospitalization, being a resident in a long-term care facility, have recent outside procedure, and probably one of the things that puts the patient at a higher risk for an ESBL infection is that if the patient themselves is colonized with or have a previous infection with an ESBL organism. So how did we approach those patients with an ESBL growing in a culture so far? Actually, for so many years, the clinician have been taught that anytime the patient have an ESBL grow in a bacterial culture, that automatically require a carbapenem treatment, namely like meropenem or ertapenem. However, is that the most optimal way to approach those patients? Is it truly that carbapenem only provide benefit and have no harm to the patient? The fact is actually quite the opposite with that, right? As I mentioned, we have an increased incidence of ESBL, and because of our practice is that anytime my patient have an ESBL, I have to treat it with carbapenem. So we have an increased use of carbapenem as well. And because of that, we create another problem for ourselves. We create another monster, namely that carbapenem resistant Enterobacterales or carbapenem resistant organisms. You may have asked how big of a problem is that? In fact, in 2017, we had 13,000 of carbapenem resistant organism cases in hospitalization, and that led to 1,100 deaths within the same year and cost the healthcare system about $130 million. That is a lot of money that we have to spend to taking care of these patients. So now you might have asked, well, I have an ESBL, but carbapenem should not be used all the time. How should I approach these patients? There's a 3 moments of antibiotic decision that I want to you think about whenever you have a patient with an ESBL organism grow in a culture. Moment number 1 is that indication. Moment number 2, antibiotic choice, and moment number 3, duration of therapy. So let's focus on moment number 1 first, indication. Whenever we talk about indication, we should ask ourselves is that does this patient truly have an infection that requires an antibiotic, or can it be just a colonization? So let's go over an example to truly understand what it means by thinking through the indication. So let's say if you have a patient who is 78 years old, female, who's transferred to your hospital from a long-term care facility after a fall. The patient reported that she tripped over her chair and fell onto the floor. For some reason in the ED, her urine culture was obtained and it grew an ESBL E. coli of more than 100,000 colonies. The patient, however, denied dysuria, urgency, frequency of flank pain. All of the vital signs labs are within normal limits. The patient had no known root allergy. So which of the following strategy would be the most appropriate to approach this patient if they were presented in front of you? So A, this patient definitely have a UTI since the bacterial count is so high in the urine culture, and since ESBL, I want a meropenem. B, the patient definitely have a UTI, and maybe we can use an ertapenem to spare a pseudomonas activity. C, patient have asymptomatic bacteriuria. We can just observe the patient off antibiotics. And D, the patient has UTI, but the symptoms seem mild, so I just gonna initiate nitrofurantoin 100 milligrams by mouth BID. So let's take a moment to think about it. What would you do if you have this patient in front of you? And with that, I hope that everybody will have to see that the patient have asymptomatic bacteriuria. We can just observe the patient off antibiotics. And the one thing that I want you to take away from this example is that just because something that grows on a petri dish or a test tube from the micro lab, it does not always mean it is an infection. We as a human being, a human body, we don't live in a vacuum, right? Our body colonized with a lot of stuff that including bacteria. And with so many cases of ESBL spreading in the community, one of us probably gonna be to colonize an ESBL. So with that, moment number 1, when you think of an indication, I want you to think about that. Even if something as multi-drug resistant as ESBL, it can also be a colonizer. And just because it grows in a culture, it does not always necessitate a treatment. So now that you go over moment number one, to think about whether or not the patient truly have an indication for antibiotics, truly have an infection, you should move over to moment number two is antibiotic choice. So now you have a diagnosis, right? You need to think about, is carbapenem truly the only option I can use, or can non-carbapenem therapy be used in those patients? ESBL, as I mentioned earlier, is a multi-drug resistant organism. However, just because it's a multi-drug resistant, it doesn't mean that it always causes severe infection. In fact, a lot of ESBL infections are urinary tract infections. Namely, for example, like cystitis. When it comes to cystitis, you have a lot of more options besides carbapenem to treat these patients. For example, like nitrofurantoin, fosfomycin, trimethoprim, sulfamethoxazole. And one of the things that the ID pharmacist favorite that we usually do is give the patient a single dose aminoglycoside. We will talk a little bit in depth in a few minutes about why ID pharmacists love that so much. Other options we can also use for cystitis, for example, like cefepime or piperacillin tazobactam. So if your patient have a pyelonephritis, for example, you still have a lot of options besides carbapenem. For example, like trimethoprim, sulfamethoxazole, fluoroquinolone, piperacillin tazobactam, or even give the patient a daily aminoglycoside to complete the treatment course. So let's go back, as I promised, to talk about why ID pharmacists love using a single dose aminoglycoside for ESBL cystitis. It is because aminoglycoside is excreted mainly through urine. So if we were able to achieve a very high concentration in the urine and it lasts for several days, studies have shown that by giving the patient a single dose of aminoglycoside, it can be as effective as giving the patient 3 to 5 day course of other antibiotics. And then it's very convenient, right? As I mentioned, sometimes ESBL leave us with no oral option. So instead of admit the patient into the hospital for an IV antibiotic, we can just give the patient a single dose of aminoglycoside and discharge the patient from the ED. Aminoglycoside also have very low C. diff infection just because it doesn't penetrate into the gut very well, so it causes less damage on the gut flora. And then another reason why to use it is because it's going to reduce the bacterial resistance. It is because we only give a single dose of aminoglycoside instead of a 3 to 5 days of broad spectrum antibiotic, right? One of the pushbacks that a lot of pharmacists will face when recommend a single dose aminoglycoside is because aminoglycoside, when used in the long term, can cause severe adverse reactions, for example, like nephrotoxicity or ototoxicity. However, studies have shown that with just a single dose aminoglycoside, the adverse reaction rate probably only 0.5%. So, namely that if you had to treat 200 patients for one of them to experience any type of side effect. So that is all the more reason why we should promote this single dose aminoglycoside for ESBL cystitis. So now in your head, you're probably thinking, okay, so for urinary tract infections caused by an ESBL organism, I can use other things besides carbapenem. So what is the role of carbapenem in the treatment for ESBL infection? When should we use the carbapenem upfront and benefit the patient? So I will refer you to this article that published in 2018. So this study actually enrolled a patient who is adult with an ESBL bacteremia. They randomized the patients 1-to-1. One group will receive a meropenem and the other group will receive piperacillin tazobactam. And what they found is that the patient received piperacillin tazobactam tend to have higher on-cause mortalities compared to those received meropenem. And from the study, what we learned is that If the patient has a severe ESBL infection, for example, like bacteremia, we probably want to prefer carbapenem over like other treatments such as like piperacillin, tazobactam. But just because we start the patient on a carbapenem for a severe ESBL infection, doesn't mean that I always have to put in a big line and discharge my patient on a carbapenem to complete the entire duration of therapy. And actually, the answer is quite opposite, right? In 2022, so a few months ago, the IDSA actually published a guidance to help us how to manage these patients with an ESBL infection. And what they recommend is that oral step-down therapy should be considered for the patient with ESBL infection when the patient obviously have an oral option. For example, like if it's susceptible to trimethoprim, sulfamethoxazole, or fluoroquinolone. If the patient is hemodynamically stable, if the patient have reasonable source control, or if obviously we have to make sure that the patient be able to absorb that, then we can just switch the patient to oral therapy. The last thing that we would want to do to any patient is to discharge the patient on a PICC line with IV therapy for the patient to come back with a catheter-related complication when we obviously have other oral options to discharge the patient with. So this is just a little bit summary about some of the antibiotics that you can use to treat the patient with an ESBL infection. So it's a graphical demonstration, a recommendation that you can refer back to. But from this, I want to remember that the moment number 2, when it comes to antibiotic selection, carbapenem should not be the only drug that you think about, because it is not the only drug that can effectively treat an ESBL infection. So now that we already talked about, like, okay, so the patient have an indication, I already chose the patient antibiotic. The next thing we should think about is the duration of therapy. What is the shortest duration of therapy that I can use that still effectively to treat my patient diagnosis? One of the common conversations that pharmacists, especially ID pharmacists, have with a clinician is that because ESBL is a multi-drug resistant organism, so the clinicians tend to be more cautious when approaching these patients, and they tend to treat these patients with a longer course of antibiotics to really make sure we eradicate the bacteria. How is that the most optimal way to approach these patients? The ESBL ultimately require longer duration of therapy. Actually, the guideline doesn't agree. So, when we're talking about the 2022 IDSA guidance document that I just talked about, they have recommended that the duration of therapy should not differ for the infection caused by the organism with resistant phenotype compared to infection caused by more susceptible phenotype. So what I mean is that whether or not the patient have an infection, for example, like pyelonephritis caused by an ESBL or caused by a pan-susceptible E. coli, the duration of therapy should not be different just because the patient have a more resistant organism growing in a culture. Obviously, we have to look at the patient as a whole. For example, like did the patient improve? Did the patient have source control? Did the patient have cleared the infection and things like that? But just because something is more resistant doesn't mean it requires longer treatment of therapy. So moment number 3, I want you to think about is that the principle of shorter is better is still apply even if the patient have an ESBL infection, right? We want to use the shorter duration of therapy that effectively treat the patient infection. So that is a lot that I just go through. So let's go over a summary just to make sure that we can really apply the 3 moments of antibiotic decision when we have a patient with an ESBL growing in a culture. 1, the growing of ESBL organism in the culture does not always indicate infection. And then carbapenem is not the only drug that can be used to treat ESBL infection. And then we should use non-carbapenem therapy whenever feasible so that we can prevent the development of carbapenem-resistant organisms. And then last but not least is that infections caused by an ESBL organism do not automatically require a longer duration of therapy. Look at your patient, right? And with that, that is all I have. Thank you so much for your time listening to my presentation.